You know what we're going to do? We're going to shift gears.
Okay.
Slightly. We're going to go from the gram negatives over to the gram positives, because we already did the gram negatives. That's why we're going to do the gram positives. And although it is tempting to say we want to talk about either community-acquired gram-positive infections in hospitalized patients, as you pointed out, it's a gray area. That the community-acquired infections and the hospital-acquired infections, they're all sort of mushing together. So why don't we start with, are there differences between community-acquired bacterial infections versus hospital healthcare-acquired infections in the emergency department, for example, specifically with regard to gram-positives?
Yeah, I mean, I think that this is another situation where it becomes syndromic in nature and what disease state you're presenting with. I think, again, we talk a lot about community-acquired MRSA with regards to skin infections, for example, but it's a certain type of skin infection. It's a purulent, it's an abscess. So knowing those types of presenting factors, like I mentioned earlier, people talk about community-acquired MRSA as it relates to things like community-acquired pneumonia. And while it's absolutely true that it's a very infrequent pathogen in community-acquired pneumonia, when it does occur, it's a nasty bug. And so when patients present with necrotizing severe pneumonia, it has to be in your differential or knowing. So what I would say, I guess, is more knowing. It's crucial that we know the patients that are at risk for it and kind of how they present, and that's when we know we have to cover for it.
If you say you have to know the patients that are at risk for it who come into the emergency room, how can you know that? If in fact, the MDR pathogens are out there in the community. Is it safe, I think it used to be safe when I was knee-high to a grasshopper, to say, oh look, this patient's coming in from home with a skin infection. It's not going to be an MDR bug. Is that a safe assumption anymore? I'm sensing it's not.
So I wouldn't say it's a safe assumption again. And so without getting into that healthcare associated piece of the story, because again, are they actually coming from home or are they coming from some other institution?
You can parse that out.
Let's take that piece out of the story and just say they're coming from home. Is it safe to say that it's not this? And I think the answer is no. In certain disease states. I think that, like I said, there are particular ways when you see MRSA present in a community-acquired infection, there are flags that kind of allude that to you. But even when you talk about pneumococcus, again, drug-resistant pneumococcus is an issue, but you'll see the same things play true. Are you in a community that has high rates of it? Are you giving has your patient gotten macrolides in the past? It's the same kind of concepts. It's just being applied now out to the community.
But are you implying, and I seem to have heard this, and I want to be very clear, that MRSA, in terms of its clinical presentation, without regard to its antibiotic resistance, it's a Staph aureus. Does it present differently than ordinary Staph aureus?
You can see an association because, again, there's a blurry line again between MRSA and MSSA because a lot of
say it depends.
It depends, yeah. but the kind of simple answer is yeah, it can present differently because the strains of community-acquired MRSA have been associated with a bunch of different virulence factors. But now that has kind of portrayed into some of our MSSA as well, which really muddies that water. But it's notorious for a skin infection, again, to see purulence, to see an abscess.
Sure.
Those are the types of things you see with MRSA. And again, you don't really see it with MSSA to the same degree, although you can. But you know that MRSA has a higher likelihood of being a player in that scenario.
Because that, to me, is a real change. Because I was always taught Staph aureus is Staph aureus, and the resistance of the Staph aureus simply means you got to treat it differently. But it's a bad bug, get it in your blood, dogs and cats sleeping together, mass hysteria, Staph aureus. And you're telling me that MRSA is a bad Staph aureus compared to others.
And I'm not saying that MSSA is a good Staph aureus, so I want to be crystal clear about that. And again,
it's just more bad.
Again, and I would say that, again, we're talking specifically in patients presenting from the community with certain disease states. And what you'll find in the hospital is a lot of those virulence factors that I talked about now exist in MSSA as well. So you see the same types of things. I think the bigger difference, at least in my opinion, is we have better drugs to treat MSSA than we do MRSA.
Right, I was going to say part of the badness is because we had basically one drug to treat them with parenterally that, we're still arguing how to dose it 3 decades later. And
this would be
it's not, yeah, that would be correct. And so, that created some of the challenges. You have a drug that probably, if it came to clinical trials today, I'm not sure where it would be, and it probably wouldn't be its positioning that it is in most hospitals now. So that creates some of the badness with Staph.
And let me nail this if I can. We're talking about a really bad actor here. We're talking about MRSA out in the community. Do we have a number? What is the prevalence of MRSA out there in the real world? Does anybody know? Really?
In terms of infections brought into the hospital, what proportion are MRSA?
What is the prevalence of MRSA
so the guys
from the
at
community that come into your
So the
ER?
guys at UCLA have probably done the best study on this. They have a multi-ER surveillance system across the country, and they say that about 30% of the staff, and this data is old, so it's probably higher now, 30 to 40% of the staff coming into emergency departments in community onset kinds of infections are MRSA. And that's a mix of USA 400 and USA 300, these kind of toxin production and non-toxin producing strains. And so again, it's a mess because these, it's a very promiscuous bug, and these plasmids move back and forth left and right. It made her chuckle.
It made her chuckle.
Well,
my daughter,
my
daughter who's 13 years old, if she heard those numbers, would probably text OMG. 40%. We are really blurring the line. I mean, the whole sense of, oh, it's a community-acquired bug, a little Vanco, go home, have a nice life. Not so much anymore, yeah? I mean, this sounds icky. How's that?
Absolutely.